Okay, so I think we're ready to get started.
Unfortunate.
Sounds like it. So my name's Kristin Carpenter. I'm president of Gamma Rho, which is our MPH Student Honor Society. This week, if you didn't know, is National Public Health Week, and Gamma Rho is hosting a few events throughout the week. And if you're interested in those events, or actually, how many of you have been to an event this week for National? Raise them high. I'm proud. There you go. Awesome. Cool. Well, thank you guys for being here. If you want to know any more about the events, just email either Jerusha Clark or mine email. Yes, so today we're really excited because we have 4 panelists. I'm just going to go across here really quickly. Jennifer Chubinski, she's from Interact for Health. And then we have Dr. Noble Maseru, and he's coming from the Cincinnati Health Department, and he's our commissioner. Dr. Lynne Sedler is the director for the Northern Kentucky Health Department. And Tim Ingram is going to be, or he is our commissioner coming from Hamilton County Health Department. And we just have quite a few questions that students had come up with, and we should have a few minutes afterwards for some questions, hopefully. So to get started, I want you guys to introduce yourselves and describe your role to what your position is in advocacy.
I'm the anomaly here. You want to start with the anomaly?
Well, good morning, and thank you for having us here today. As was stated, my name is Tim Ingram. I'm the Health Commissioner with Hamilton County Public Health. And health commissioners are, there's a lot of people wonder about the structure in Ohio and the public health structure and so forth. As a matter of fact, I was talking with a gentleman about that structure in Ohio. So in Ohio, there are 123 health districts within 88 counties, and health districts are special units of government governed by a board of health who I report to. So my role, they're an appointed board appointed by a political structure composed of county commissioners, township trustees, and mayors. There are 49 units of government in Hamilton County being a relatively old urban county, and that's very typical in Ohio when you go to urban counties that you have lots of units of government. So my role as county health commissioner is basically to carry out the policies and regulations of the Board of Health, who they have authority to adopt, and also those that have been handed to us by the Ohio legislature as law. And so we have a workforce of about 85 folks, and we have a very strong health promotion and education section, along with the other programs that you're going to hear about today as we talk about my role in advocacy. And actually, I believe that that's one of the biggest things I do is actually help create and implement policy. Some of those policies I don't actually like too much, but you do what you have to do. And other ones I try to modify through using data and the power of persuasion. Because although public health is inherently grounded in science, and we always use the science first, you cannot forget that public health decisions are, quite frankly, in our society, political decisions. So we have been in existence as the county. We serve about 500,000 people. We serve all units of government except for 3. Lynne?
Tim is always a hard act to follow. There are many similarities between Kentucky and Ohio, and there's many differences when it comes to public health as well. The Northern Kentucky Health Department is a district health department. It's an independent district health department, which was created specifically by Kentucky statute. And we cover 4 counties, Boone, Kent, and Campbell, directly across the river, and then further south we have Grant County. So we have everything from urban core to rural tobacco farms in our district. And I wanted to talk about advocacy because, as Tim says, it is a large part of what I do in my job, because a lot of what public health is about is trying to create policy change, environmental change, systems changes, and that requires a lot of advocacy. And I'm hoping by the end of this morning, you'll have a clearer sense of what is advocacy and some real sort of practical understanding of it. When I jotted down some notes for the panel today, I really thought through what do I wish I had known 20 or 30 years ago about advocacy rather than having to learn by trial and error. So hopefully with age comes some wisdom that we can share with you.
Good morning, everyone, and thanks for the invitation. As Tim has noted, we receive our authority from the legislature of the state of Ohio. Additionally, in Cincinnati, that authority is also embedded in the charter, the city charter. Health Department has been around since 1826. Our span of control is around a population and workforce of about 411 folks, and our budget is $40 million. In terms of advocacy, there are three areas that we believe are essential for us, and obviously leadership, and certainly along with that we're talking about resources, the management, and the distribution of resources, and also power. Those three elements in terms of resources, power, and leadership. One piece that is not mentioned is charisma. I don't have that. The other three areas is very key. You got to have those. You can go with at least three, but one of those you can do without. You can figure out which one that is. In terms of our health department, and we'll talk about this in more detail, health equity is a key focus of our department. We believe that elimination of health inequities is a moral responsibility for our department and our office in particular.
I'm Jennifer Chubinski. I work at Interact for Health. We are not a health department. We serve the 20 counties in the Cincinnati region, including all of the areas that these three health commissioners serve. We are a nonprofit focused on improving health, specifically around healthy eating, active living, healthy choices about substance abuse, and community engagement. Many members of the community are most familiar with our grant making. We are what's called a health conversion foundation. That means that about 20 years ago, a for-profit health insurance company was sold to a not-for-profit health insurance was sold to a for-profit health insurance company, and the profits of that sale remained in an endowment, which at the time was the Health Foundation of Greater Cincinnati. We have since changed our name to Interact for Health, and we work closely with all three of the health departments in trying to improve health in our 20-county region. I am the director of community research there, so I do a lot of data collection and work around measuring health and health public opinion in the region that we serve. Because of the origin of our money, of the endowment that the organization lives off of, we have to be very careful around health advocacy and cannot advocate directly on pending legislation, in particular in Ohio. So while we do fund projects that advocate for better health, and we fund any number of organizations across the region, we have to be very careful when it comes to certain forms of health advocacy.
Thank you for your answers. The students also want to know, what are your current public health advocacy projects that you are leading in your community?
I'll jump in here because we just finished our 2015 General Assembly, which is our legislature for the state. And we were very active this year in a lot of advocacy. And as Jennifer said, advocacy is not lobbying, and we cannot lobby, but we can advocate. And hopefully by the end of this morning, you'll have a clearer sense of what that is. We were very involved this year in advocating for Smoke-Free Kentucky, which was a comprehensive statewide smoke-free law that would prohibit smoking inside all public places and workplaces. And a lot of our work in Northern Kentucky was funded by Interact for Health, which was very helpful to have those resources in order to do some of the work, like a lot of the media campaigns, the advertisements, the bus ads, a lot of social media work, a lot of pushing messaging out. As well as going down to our state capitol in Frankfurt and talking to legislators about the benefits, the cost savings, and working with our community partners like the Chamber of Commerce and many other people. So smoke-free was a big push this year. Unfortunately, the law did not pass. It made it through the House and was sent to the Senate, where it was sent to a hostile committee to die, basically. And so we didn't get smoke-free, but we were also working on heroin and getting a comprehensive heroin bill. You may have heard in the news over the last 2 years, we have a very serious heroin epidemic going on in northern Kentucky, not unlike what's happening on this side of the river. And so in last year's General Assembly, we tried to get a comprehensive bill passed to help us address the heroin problem. It did not pass. So this year, everyone was full force in Frankfurt trying to get something done, and a bill did pass. And in spite of the fact that we have been told for 2 years there is no way you will ever get needle exchange in the law, we got needle exchange in the law. And so that's going to lead to other advocacy efforts as we are putting together a needle exchange program. We've obviously got to educate the community so that there is community support for a comprehensive program. And then the other area, which you may not think about in public health, is I did a lot of advocacy work with some partners on getting them to change the law that determines the size of my Board of Health. My district Board of Health has 32 people, and it grows based on the population. And if you know anything about boards or committees or anything else, 32 is way too many. And so this is the 4th attempt that we made to get the General Assembly to change that law, and they finally passed it. So my new board in July will be 21 people, which is still a lot, but it's much more manageable. And so it did require a lot of talking to folks, explaining the benefits, and as Tim mentioned, a lot of this stuff is about relationships and building relationships with policymakers, decision makers, and partners who can help be your champions, and doing that before you need their help or before you need to ask them for help.
So Cincinnati 2010 census, 296,000 folks in the city. So our responsibility is to attend to the needs of that citizenry in terms of wellness, protection, and prevention, but also attend to the needs of our visitors to the city. Health inequity, we more or less decided how should we address this, and so we looked at the World Health Organization as a reference point. And as you know, the Human Development Index is used by WHO, and they employ income, education, and life expectancy. So in Cincinnati, Dr. Camille Jones and her team determined in partnership with Xavier University, I should add, what the life expectancy is for Cincinnati as a whole, but also specifically in 47 neighborhoods. And so the range was as low as 66 in South Fairmont to as high as 88 in the Columbia-Tusculum. So we've needed to address why that discrepancy exists, and so we can talk about that as well later on. Data is important. Reliable data is important. So poverty is another area that we decided that we would address in terms of the elimination of poverty. So all of our programs that we have, in addition to be thinking entrepreneurially, we also want to talk about economic self-sufficiency. In terms of life expectancy, we know that infant mortality, and we like to attend to it as infant vitality. And so in 06 to 2010, we noted that the infant mortality rate for the city of Cincinnati was 13.3. However, when we looked at the numbers for our infant vitality surveillance network, which comprised of community health centers, our partners at University Hospital and the health department, that IMR was 9.2. So roughly there were 5,400 deliveries citywide, and we figured how could we address the infant mortality rate, which was as low as 0 to as high as 34 in some zip codes. And we decided that we would address those zip codes that had an IMR of at least 10 or higher. We approached 3 hospitals to assist us in attending to those zip codes that had an IMR of 10 or higher, along with home visitation agencies. And so in 2013, we launched the First Steps program, and in 2013, we had the lowest IMR in the history of the city, 9.9. In 2014, with our provisional data, we have an 8.4 IMR. And specifically in terms of the health department, we've hit the prematurity percentage for Healthy People 2020 in the last 5 years. So the data is important, addressing health inequity and providing some particular pathway for social equity through social economic self-sufficiency, and we can talk about that, Dr. Mooney's program and what we're doing in that regard in terms of education. Oh, sorry.
You want to go, Jen?
I'm-
Let me just talk about probably one of the major policies proposals that are currently is going through the Ohio legislature. What piece of legislation do you think influences probably more policy for the next 2 years in the state of Ohio than any other bill that could come after? What piece of legislation that's currently being debated? It goes to what Noble was talking about, deciding who gets what, when, and where, and how resources are allocated. Go ahead. Absolutely, the budget bill. It is a major piece of legislation that occurs in every state and in this country, either every year or every 2 years. So Ohio is now in the throes of debating that budget. Thank you. And there's 2 key issues. Actually, there's 4 key issues in the budget that affect public health. And I'm going to speak to really one. And we can talk about a couple of the other ones as we develop our program here today. Excise tax on tobacco products. I am pulling for Dr. Sadler and all her folks in Kentucky to become a smoke-free state, because Ohio is a workforce or a workplace smoke-free workplace state, and that did not occur without a lot of work. It happened in 2007. It took the will of the voters to convince the legislature that this is what they wanted, and then it had to be enforced, and we've been actively enforcing that law within Hamilton County Public Health since it was enacted. Just to let you know, our complaints, we were getting, and it's based on calling the 1-800 number. You don't hardly even see the signs anymore, but because it was 60% of the workplaces when that bill first passed were found in violation of smoke-free laws. And now I can tell you that's under 10%. And mostly it's just some bars and taverns, some rogue bars and taverns that we're still dealing with. So why is the excise tax proposal that the governor put in the budget so important to public health? Because, you know, one of the we know tobacco is a leading cause of many diseases in our society. It's been so well studied, we really don't need too many more studies, I don't think. But yet, one way to effectively curb tobacco use is to continue to denormalize it from our society. Pricing it is one way to do it. And so Ohio's current excise tax on tobacco products is $1.25 per pack of cigarettes. The proposal that's being debated now in the legislature is to raise that tax to raise that to $2.25, another dollar. Very important. Just to put it in perspective, New York has a excise tax on tobacco products. I think that's almost $5 a pack. So these are ways in which policy creates public health progress. So I did want to bring that to your attention. I would hope as public health professionals and advocates that you would, and if you live in Ohio or if you don't live in Ohio, I hope you would weigh in on that and contact your legislature. Here's a good chance for you to begin to develop a relationship with somebody who is key to the future of health in our society.
So my answer is a little bit different. We at Interact have the luxury of not being subject to a budget bill periodically, and so since we live off in an endowment and live within limited constraints that were placed on the way that we spend the money for health improvement, we actually have the luxury and the responsibility to the community to spend the money in a way that improves the health of our whole region, and to do it to support the work of the public health departments as well as many, many nonprofit organizations that are working to improve health in our region. And I wanted to respond to several of the issues that my co-panelists brought up. Related to the smoke-free law in Kentucky, we've been collecting data on public support for that legislation in Kentucky for many years, and it has been several years that the majority of Kentucky adults would support that kind of legislation. And yet, every year we get one step further in getting a smoke-free Kentucky, but we're not quite there yet. So even when you have high-quality data, high-quality public opinion data showing support for legislation, there's still, back to what Tim said earlier, there is still a lot of relationships that are required, and there are just a lot of political pieces to the discussion that go beyond the facts or the data or the fact that we know that having a smoke-free environment would be better for everybody's health. I also wanted to comment on the heroin work. We, as Lynne suggested, we've funded a fair amount of that work and have collected data on that as well. And in Kentucky, we see a lot more Kentucky adults reporting that they have friends and family who are having serious problems because of heroin. We're talking about 4 or 5 times the rest 4 or 5 times larger than the rest of the state. Now, we don't really believe that the heroin problem in northern Kentucky is 4 or 5 times larger than the rest of the state. We believe that it has to do with the awareness because of the work that Lynne and many people are doing in the community. But you see that awareness being played out in the data that we collect, and I would like to say much of our data is made publicly available, so if any of you would like to get your hands on it, you can go to interactforhealth.org. Specifically, the raw data are available for those of you who need data for various projects at oasisdataarchive.org. It's free. You can use all the raw data. You can manipulate it in SPSS and use it for various projects, and we hope that you do. That's part of the community benefit and the reason for investing the money that we have.
Thank you. So how do you determine which public health issues get priority attention with relation to funding, policy, and or fostering change within your constituent communities?
I'll jump off on this one. Okay, so in terms of success, or at least the effort to accomplish that, it can't be done certainly by ourselves. When I say our, I'm talking about the health department. So our achievements and what we've done has been through strategic partnerships and collaboration with other entities and agencies. And Interact for Health has certainly been in the forefront of much of what we've done and been able to do. So in terms of making a determination as to what areas that we wish to address, as we noted, certainly poverty and chronic disease. Chronic disease is definitely a driver in terms of what is the differentiation, if you will, in terms of life expectancy. So we look at things upstream as well as providing an attention to the treatment or curative downstream issues. So in terms of upstream issues, we're advancing things that looking at zoning laws in our neighborhoods and communities. We're looking at what effect does deconstruction have on neighborhoods and communities, and we do that through health impact assessments. We look at what is the role of gender and race in terms of affecting decisions, and in terms of who has their hands on the spigot for the distribution of resources, and what kind of views and values are those individuals that have their hands on that spigot for the distribution of resources. So we have to use data in terms of looking at how the current resources or potential resources are employed or not employed. So the return on investment is another methodology that we employ. In terms of downstream as well as upstream, we look at what's important, what are the valuable kinds of agencies or entities that are key for a city to thrive, and certainly our public school education is one of those. We have the Affordable Care Act, which is allowing us to, in 2007, 58% of our clients were uninsured. Now only 23% of those clients are uninsured because of the Affordable Care Act. In advance of the Affordable Care Act, we have nurses in all of our elementary and middle schools. Today, through the leadership of Dr. Marilyn Crumpton, we have, in addition to nurses in our elementary and middle schools, we have 11 school-based health centers, which also are led by advanced practice nurses. So those individuals in those school systems are not just addressing what's taking place curatively, but what's happening and what's needed to be done in terms of health promotion and health prevention for that school body, that enrollment, but also in terms of the neighborhood. So we're reaching out into the neighborhood through Darlene Kamine's community learning centers. So what we're seeing in terms of Cincinnati is that we have an opportunity for a city that's only 296,000 folks, has a poverty rate of 33%, and for children it's 53%. How do we eliminate that? And we'll share with you our views on how we can eliminate the poverty rate that's taking place in Cincinnati on the next go-round.
Okay. Sure. So I would just say that data is the key. You always lead with the data. You know, we are scientists trained in the sciences. We understand the importance of data to make an argument. But yet, in the roles that we serve as health commissioners, as I said earlier, you got to understand that it doesn't matter how persuasive the data may be to those who have, as Dr. Maseru said, hands on the spigot, those people that are making decisions on policy that determines the distribution of resources within your community or within the society. We have a very strong epidemiology section at Hamilton County Public Health. I would encourage you, if you haven't went out to hcph.org, to go and look at what type of reports that we're putting out regarding the face of certain diseases. Because it's really, data is convincing to us because we're scientists first, but the truth of the matter is you got to humanize the data. You really do. You got to put a face on the disease. And what has occurred with the infant mortality issue in this county is really about humanizing the face of that problem to where it's now we have lots of momentum going on through many efforts here, as well as through an organization known as Cradle Cincinnati. And, you know, I want to just say, and I know I'm going to actually probably answer a few other questions that are on the list, but, you know, you want to give people an opportunity. Once the data says you have a problem, and obviously we're going to talk a lot about heroin and the issues that it's causing in our society, but you want to take the data to a person who's in a role to give them what I like to call, you champion them, you give them a hero opportunity, if you will. And if you had to say one state senator in Ohio who has become that champion with infant mortality, it's State Senator Shannon Jones. As a matter of fact, she is so passionate about this issue, and she happens to be a person that's is in leadership because she chairs the Senate Health and Human Services Committee in the state of Ohio. And she is with the majority party, and so you need to understand the legislature. But this just came out today, and she said let me just read this real quick because I think it makes the case of why you need to find these legislative champions or policymakers that you can give them an opportunity to be out there, the spokesperson for the problem, but you're working behind the scenes, providing the data, give them the support and so forth, so they can actually tip the majority in the favor of doing something that's a public health issue. So I'm going to read from this monthly monitor that comes out, actually maybe weekly, called the Capitol Monitor from the Hannah News Services, which watches over some of the state capitol affairs going on in Columbus. And it says here, Senate Health and Human Services Committee Chairwoman Senator Shannon Jones, Republican from Springboro, Ohio, used the appearance of Ohio Department of Medicaid Director John McCarthy. Okay, there's a person that's on the payroll in the executive branch of government. He heads up Medicaid in Ohio. Big issue, big program. And she used his appearance before her committee on Wednesday, March 25th, purporting to present his department's 2014 report, but he basically turned to where she began to press him on what his agency is doing to address a major concerns of hers, infant mortality. That's advocacy for a public health issue. She's on board. We got a champion. We are lowering the infant mortality rates. We will lower the infant mortality rates in this state as long as you have people like Shannon Jones and good people working behind the scenes to implement the programs that we know that are effective.
Well, just like you heard from other folks here today, it really does start with data. Health departments tend to do community health assessments and look at the data in a comprehensive way to figure out what are our community's big health problems, and from that develop a community health improvement plan. We're a nationally accredited health department, and so we are required to do that. Every 5 years we have to do community health assessment, community health improvement plan. And of course that drives what our priorities are going to be for the next 5 years and feeds into our strategic plan, our program plans, our budget, and all of that. And so it does all start with the data. And as you've heard Noble speak about and Tim speak about, we're looking at health in a more comprehensive way, not just what diseases, what are people dying from. We're looking at it in its broadest sense because, for example, we know education, income, and health all go together. And so we are very concerned about our kindergarten readiness rate and the percent of kids reading at grade level in third grade and those sorts of things, and the high school graduation rate, percent of folks who have their bachelor's degree, and so on and so forth, because we know education plays a role in health. We're also interested in jobs and economic development, and so we're very involved with our Chamber of Commerce, who is progressive enough to recognize that health is a key piece of what they need to be concerned about with workforce. It's not just having an educated, talented workforce, it's having a healthy workforce too. That makes a difference in economic development. And so in the process of developing a community health improvement plan, we use a model that many other health departments do. It's a national model called MAP, or Mobilizing for Action Through Planning and Partnership. Some of you have probably heard of that. And we have used it, this is our third time of using it in some form or fashion. And the important part about that is you're engaging your community and you're engaging your community partners. And they are helping you discern and analyze what is this data telling us and what does it mean in the context of our community. So they're helping, your community is helping you define what the priorities are. And your partners are also saying what they can bring to the table in terms of resources or partnerships for advocacy and other kinds of things. And so I think those are very important to have. The other piece that Noble has touched on is when you're looking at the data, you're also looking at it from a health equity standpoint, or you should be, because even though the data may look great for your community, you really need to dig down and see, is it looking great for everybody in your community? Or are there disparities that need to be looked at and addressed? Because the reality is we want everyone in Northern Kentucky to enjoy good health, not just the majority or a certain segment of the population. And so that's another piece of what you look at when you're looking at what are our priorities.
Our policy and funding priorities are determined by our board, which is luckily less than 32 and 21. Our board of directors is publicly available on our website. They're community members who help us determine our area of focus. Their decisions, of course, are highly informed by our staff. We have about 25 FTEs, many of whom are deeply embedded in the community and in various projects. So the board determines the broad focus. The staff makes suggestions about how to fill that in around funding and policy priorities.
I'm going to skip maybe a couple questions on your sheets just because we might run out of time. The next question I wanted to ask you guys, what partnerships are necessary in advocating for public health issues?
Every partnership. You cannot have, when you are, so let me take a step back. Our role is obviously different. We cannot lobby. So we can fund advocacy work. We can fund data collection work. We can do a lot of work around health issues. We cannot lobby. So we have to be, Interact has to be very careful about the partnerships that we ourselves have, although we can help facilitate critical partnerships in the community. And I can't, I have to ditto some of the comments that my panelists made earlier about making relationships early and before you need something so that you can pick up the phone and they know who you are and they know what your expertise is and will take your call and listen to what you have to say. And repeated contact and lots of people with the same message, especially voting constituents. I think that's all that I can probably say on tape.
You can use invisible ink and on that signature.
Is that right?
I think it depends on the issue. You need to know you need to know all the players and kind of the brokers, if you will, for my phrase in the community. Every community has its unique set of characteristics, demographics. That's what allows the data to do. You heard Lynne speak to and Noble. It's not. You have to drill down. You get in behind the data, understand the reasons, perhaps for some of the behaviors that are occurring, and that will get you down in kind of the roots of what's going on in the community. It is really trying to identify the hot spots that will allow for some movement and change of the broader barometers that we use to measure our health status in our society.
Tim is right. It does depend in part on what the issue is that you're trying to advocate for or against. But I always start by looking at who has a stake in this issue, both in terms of who might be the opposition and who might be supportive of what it is that I'm trying to advocate about. And then I look at, well, who can influence them? Because I think it's important if I recognize that it's a city commissioner that holds the key and I need to be able to get to them, I may not have as much influence as their next door neighbor. And so if I know their next door neighbor, I can talk to them and get them to talk to the commissioner and they will have more influence. So it's really, we keep talking about going back to those relationships. because that really is what is important. And finding your champions. And sometimes they are in the most unlikely places. You usually think of sort of the traditional partners that you're going to get to advocate on an issue. But I tell you what, with the heroin issue in Northern Kentucky, our best advocates in Frankfort were moms, were parents, were grandparents, because hell hath no fury like a parent who has lost a child to heroin. And we would not have a comprehensive heroin bill if it were not for these parents and grandparents down there.
So we have this integrated preventive and primary health care network, and what that means is essentially the public school system, Cincinnati Public Schools, where the health department is the medical and public health consultant for the school system. We have our community health centers, and we have the health department. So that's essentially attending to really more than 60,000 folks. We serve 45,000 folks in our health centers. There are 34,000 is the enrollment of the Cincinnati public school system. So additionally, in terms of partnerships, then we want to be thinking about the philanthropic community. Rockefeller Medicine Man, you might want to check that book out by E.R. Brown. That gives you some what's happening there. Additionally, we're looking at, I mentioned Dr. Jones in terms of what's taking place in terms of neighborhoods and community environments. So Cincinnati has a Safe Streets program, walkability, safe streets, so we're looking at that with Dr. Jones and Denisha Porter, wellness and those kinds of things. So we meet every Tuesday with our other department heads in the city. So planning, economic development. So we're connecting with these individuals and developing strategies that we would like to partner with them on in terms of zoning and having inclusion in terms of workforce development. So I mentioned the discrepancy that exists, 66 years to 88 years. New York City reduced or expanded the life expectancy 3 years, from 78 to 81, from 2003 to around 2012. So it can be done in terms of extending the life expectancy. It's not out of the realm of possibility. Cincinnati, 76 is the life expectancy. It's 78.2 for the United States overall. We believe we can reach that 76, and we believe that we can have some greater equity in terms of what the differentiation is in terms of life expectancy. And one approach that we are certainly advocating is addressing poverty. How do you do that? Well, guess what? In terms of the median income for individuals who are tearing up those streets that you see when you drive through the neighborhoods, 43,000 folks, $43,000. In terms of the quintile, the middle quintile for the middle class, the pathway to reaching that middle quintile, the lower threshold is $38,000. We believe if we can have greater representation, equitable inclusion on those jobs, those folks who are working on those streets, that reflects the neighborhood and the community that we drive through, that you drive through every day, we can reach that $38,000 mid-quintile within 3 years. That can be done within 3 years because the skills and education that's required to do those kind of jobs is not something that's out of the realm in terms of technology and all of that. So that's one real pathway. So in terms of partnerships and these kinds of things, advocacy is an issue that we are pushing forward, but there is a cost to that. It means that there's a status quo that may not want that to happen. And so we still must continue to push that envelope to make that happen, in our view. So we can talk about the details of that, but certainly April 4th was a day that many of us recognize in terms of the assassination of Martin Luther King. Social justice, poverty, what took place in Memphis, and the stance that was taking place during that period. This is what needs to take place in our city if we're going to have greater inclusion and not have situations that occurred at Milrose where young people are getting shot. those kinds of issues in terms of addressing economic inclusion will reduce the threat of those kinds of things that's taking place in our neighborhoods every day.
I just wanted to add, I just was sitting here as everyone was commenting about, there's one partnership that is that we would be remiss not to mention, that is the hospitals, the healthcare system. There is major, I don't want to get in a lot of, we can expand on this later if you'd like, but there's obviously a major healthcare transformation going on. Just in our medical community, how we provide care, how physicians and physician extenders are employed, and so forth, and the movement by the payers, either through the Affordable Care Act, through Medicaid expansion, and commercial insurance, that they are insisting on better value for the price that's being delivered, or the care that's being delivered within our and in the walls of our system. So, it's a sickness system. We know we go into the hospitals because we're sick. We're going in there to get fixed for something we could have been possibly prevented upstream. That's public health. The buzzwords and the things that you're hearing all the time now in the healthcare system is population health, population health, population health. Is population health public health? From our perspective, it is. And I would ask you, if we had several people from within the administration of the hospital system, that they would see us as a part of the population health equation that they're looking at within their systems. And I would beg tell you that there would be a difference in discussion on that, and I will leave that alone as a teaser.
I wanted to follow up on some comments too. I think one of the things we haven't talked about here is when you put your position out publicly or your data out publicly, you no longer control the message. So sometimes what the public does with what you've put out there is not in line with what you had hoped. So we have collected lots of data in Ohio before we had the smoke-free law. See, even for emphasis. And we had collected a bunch of data showing strong support for smoke-free laws in the workplace. And it was about split on restaurants. And there was a majority of folks who didn't want a smoke-free law in bars. Well, these data were not fully in line with what we had hoped, but we released them publicly because that's the principle of Interact and being transparent with the data that we collect. And what happened after that was that our data and our press release and my quotes in the press release were used all over the pro-tobacco and pro-liquor lobbies as they were working against the smoke-free Ohio bill. So, when you put things out in the public, you can't control anymore how those data in particular or your message is used. The same thing has happened in Kentucky as we collect data on marijuana. And our marijuana data are being used to argue for the legalization of marijuana in Kentucky, which is not in line with Interact's policy on marijuana. So, you do the work and you put it out there publicly, and sometimes it's not taken up in the way that you would have hoped. So,
Thank you. That was some really awesome responses. We're going to ask one more question, and then we're going to open it up for other questions. So with the looming measles epidemic, this has kind of highlighted the importance of vaccinations. How do you encourage immunizations in your community despite the controversies?
Go ahead.
I'm so glad you picked that one. I had an interesting experience when the whole measles thing was going on. You might remember the media jumped all over Senator Rand Paul for what he said about immunizations. Of course, now he's declared his candidacy for president. And because he was from Kentucky, all the media over here wanted to talk to me about what I thought about that. And so I had to come out publicly and say he's wrong. And I still have my job, luckily. If he gets elected, I probably won't be Surgeon General, though.
We're pulling for you.
And I think with that issue, that was kind of an easy, no-brainer issue to me, because the evidence is just so irrefutable about the benefits of immunizations. And if you keep it's easy to take a position on that and hold the line. There's no gray area when it comes to immunizations, and I think it seems to have worked well for certain political parties, which I shall not name since I think we're taping this. But if you say something emphatically often enough, people will believe it, even if it's not true. And this is a case where it's very clearly true, and there's plenty of research to back that up. And then if you also address what the opposition is saying by explaining about how that research was found to be fraudulent and just isn't credible, and you discredit things from the past. And you also bring up other things about, the whole notion about it, people want to, go back to organic and natural and whatever, and, reminding them that 100 years ago, when we didn't have immunizations, lots more infants and children were dying of these diseases. And then the other argument that we use, it just sort of depends what the opposition is throwing at you, but the whole opposition of it's not just about your child, it's about the children that your children are around and are playing with. And if you care about your neighbors and your family members and the kids that go to school, you're doing this for them as much as your own child. And so that's how we've been approaching it. We have very high levels of immunization in Kentucky, but in northern Kentucky in particular. And for the kids that come to our health centers in our 4 counties, we've been over 95% for a number of years now. But we have to work really hard at that and educating parents why it's important. We have some folks that claim the religious exemption, but we still educate them to make sure they're making an informed decision.
Well, this is one of those situations where Cincinnati, being 10 years behind, the resistance for vaccination hasn't caught up. So we're very thankful there. We have our community health centers and the health department is 92%, and in our schools where Maryland is at, it's in the 90 percentile as well. So we're pretty thankful there. Where there's quite a bit of work that needs to be done is in the private sector, physician offices. The rates there are around 78%. So Beth Gay and her team is working very aggressively to address that.
Go ahead.
Interact is not working directly on immunizations, but my household is 100% immunized.
So is mine. I'll second that one. So I was just going to, this really did raise an interesting question. And you've heard some of the data. We should be saying we're 99% immunized in our society. We shouldn't be talking 87% or 92% or anything. We should be 99% immunized. So this really came to light. In 2000, I believe, if I'm correct, CDC had almost eradicated measles from the United States. We were so close to eradicating measles, and now we've obviously slipped. One thing you can always do is you can always write an editorial, inject the facts into the debate, as I did in February. Social media, you guys are, as I look across to the cross-section of young leadership coming into play here, social media is very, very powerful way to keep the right facts out there. But there are conflicting and opposing forces out there. And there was a great study that was just done, that was just released from the Journal of Medical Internet Research in October of, I guess it was published in October 2014, about tweeting for and against public health policy, response to the Chicago Department of Public Health's electronic cigarette Twitter campaign. You might want to check that out. It's very interesting. As a matter of fact, they did something, I learned a new term when I was reading it, called astroturfing. Maybe you already know what astroturfing is. That's when certain, in this case, companies that had an interest in making sure that policy did not get passed, they bombed the Twitter feeds to try to oppose that push. So remember, this smoke-free state we have, workplace law we have here in the state, is always subject to attack. And so we never want to take that for granted. It's like we don't want to take our health and our sanitation for granted. So one more thing on the measles. And so when we had the outbreak in central Ohio, when the good people that went over to the Philippines to help them rebuild their country, unvaccinated, walked right into a measles epidemic, came back to central Ohio, was a part of a culture and a community that did not vaccinate their folks, and obviously we had a measles outbreak occur. One can talk about should Ohio law be changed in that regard. I actually had a discussion with one of our congressmen about perhaps creating some federal policy in that regard, and that is, states are going to do what they're going to do. They're all unique in that regard. But, should we allow folks to leave the country and going into a known endemic or epidemic outbreak of a communicable disease to only then return and spread it among cases within the country? You would never do that if this disease was been declared a terrorist agent. Okay, you wouldn't. Look at the response we've done with Ebola as a country, anthrax, and so forth. So it was an interesting discussion. The congressman, he actually became engaged in this. And so the point I was saying to him, shouldn't we require vaccination before you leave the country? If we know we have science tells us they're walking into an area and they're an unvaccinated group of people that could actually hurt the country when they hurt a community when they come back. Advocacy.
Okay. Is there any faculty or staff that have any questions? Because the students can always ask questions in the next session for lunch. Okay, we have 2 questions. I'll come over here first and then get to Dr. Yang.
Alumni, not faculty or staff, just to clarify. But I had a question. We've had a lot of really great publicity in the last couple of years around public health topics. I'm thinking of like heroin and infant mortality, where the public becomes really aware through news stories of the issue. How do you kind of maintain that advocacy and that long-term push a couple years after, when no one's thinking about infant mortality anymore because it's not in the news?
So I'll take, I guess, a stab at that question, so to speak. Everybody follows the money. I mean, truthfully, when it comes down to the end of the day, and that political process of, distribution of resources is always going on, as it is right now in Ohio. I believe that the best way to keep these type of programs alive or well is to create an infrastructure at the areas in which we know that are subject, perhaps, and we've got to be careful because we could get blinded with saying, that it would never happen over there. Well, yes, it can happen over there. Where you create an infrastructure that allows for, hopefully, funding at that community level to allow that program to continue to perpetuate. I mean, I think that's the key. I hate to use the term institutionalize, but if you can institutionalize certain things and make it a part of the budget process every time the budget's being negotiated, that this is kind of like this is an untouchable, if you will, then it will stay on the radar and it will stay implemented. I hope.
I know we do a lot of work with the media on trying to keep issues in front of their mind. And it might be, we're tweeting out this year's infant mortality rate, or we're releasing a press release on something. So issues that are of importance to us to keep in the public eye, and either to show we're still having an issue or to show we're making progress and we need to continue these efforts. So we don't just wait for the media to come to us. We use the media as well to push our agenda as well.
And I would say we all, as a group of public health professionals, really need to work on positive messages about public health, because we find the media really likes the negative. The county health rankings came out a couple days ago, and we're at, Hamilton County's near the bottom. Well, that's a great story. Well, what about the fact that Warren County's near the top, or some of the Kentucky counties are doing really well? I remain disappointed over time in the media's draw to the negative version of the story and not the positive, and we struggle when we talk to media representatives with trying to get them to look at some of the progress that's been made and some of the positive stories that are out there, because there's a tremendous amount of great work that's happening in our community.
Jane, I'm the MPH director in the department, so welcome everybody. I really appreciate you come and give the talk. I think it's just wonderful panel discussion. I have two questions, or maybe just seeking the comments from you. So there's a lot to mention about the data, and also lots of discussion. Tell the audience there's actually a long way from data or evidence to the health advocacy and the health policy. So this is a very, to me, I think personally, this is something really appreciate. You mentioned those in the discussion. Another things I think Lynne and Jennifer also mentioned about is pretty much my interpretation is if you have a data, really you need, you mentioned about you need to dig deep. And Jennifer also mentioned data is just belong to everybody. It's just no biasness, anything. But the interpretation could be different depending on where you come from. My understanding from my perspective, really, at least for the data, good data, you really need a good analysis. All kind of things will end up with two questions from my perspective, which is from the MPH program. So one thing I want you to give the comments to our MPH students, and I believe after this talk, everybody has to think about how they're going to jump into the field and apply their knowledge to the public health. So I want to seek the comments from you and to see what do you put your perspective on the students, how our students can make the impact to the public's health and policy in the region. My second question, and also seek the comments from you, is from the research perspective side. I know there's a lot of faculty also be in this meeting today, and they listen to the discussion. They may also think it's what we can contribute to the research, and from the academic perspective, how we're going to work with you and make these health issues and make the public health better in this region. So thanks.
I'll take a stab at the first question. First off, in terms of partnerships, the academia is definitely one of those areas or sectors that is integral to what we do at the health department. Clearly, the MPH program here at UC, we've been involved from even before its inception, if you will. So we have opportunities for students to participate in capstone as well as shadowing or short-term research projects. We have collaborations with all of the entities here in the UC area, College of Nursing, et cetera, real projects. We mentioned Xavier. We have a project with the DAP. They're doing some renovation and design in one of our health centers in collaboration with Cradle Cincinnati. We have Michael Rentz, who's around here. I think he's around here. Is he dashed? Oh, there you are, Michael. So Michael is he's working with Dr. Crumpton and is it Shivathan? Okay, yeah. So we had the pleasure of meeting him, and hopefully we said a few things that perhaps won't chase him away, and he'll come in and have an experience with us. And of course, Chuck is out there, so he has definitely been a champion and support of what we've been doing. But I would be remiss if I didn't recognize our employees, our workforce. Clearly, what we do and the efforts and the success and what's taken place is really what those individuals within our organization, what they're doing. And so we have a participatory process in our health department. So I just want to state that they are essentially your champions because we work for you. We almost have eliminated the designation boss out of our lexicon in our organization, but we serve you. We serve the citizens of Cincinnati. So I just want to underscore that.
So I interpreted your first question as advice for students. So my advice to all of you as somebody who is a quantitative person is to collect as many skills as you can when you're in school. I know it seems hard, but it just gets harder to keep your skills up when you leave. And folks with quantitative skills, you may or may not ever use them, but man, you'll stand out as an applicant if you have them on your resume. So go learn and soak it all up when you can. I would also say network. Even while you're a student, I meet with students all the time. I'd be happy to meet with anyone in the room. All of my colleagues do the same. I imagine everyone on this panel and their staffs do the same. You know, if you have questions about I'm sorry, I just volunteered all of you. I'll volunteer myself. I'm happy to meet with anyone in the room. There are lots of ways to figure out how you fit by talking to folks who are doing work that looks really cool to you. And if you keep asking people that are doing work that looks cool to you how they got there or what they did, you might find a space that's a good fit for you. Since Noble was name dropping, I'll say we have a current student on our staff as well, Kelly Adcock, who's working with me and is here today with her smiling face to be supportive. Back there, the one turning red. And I think your second question was more about partnerships with faculty. Is that what you were getting at? Interact would actually like to do more of that. We haven't done a terrible amount of research, although we're working in that direction, and most of our research is applied, so very project-specific, issue-specific. We do a lot of telephone interviewing to collect the data that we have, and we'd like to do different methods and different ways of doing that. So I think I'm opening the door to have those conversations, but historically we haven't done a lot of that work. And certainly we are not the National Institutes of Health in that we don't have massive funding for research. The grants that we give for research are relatively small. So I would love to talk to faculty who have ideas in the areas of focus of Interact.
I can jump in real quick here. We have, as part of our health department, the Public Health Institute, and that's our program for connecting with universities and with students and research and all of that. And we are always having needs for students. And the way we look at students is we're interested in wanting to know what is it that you want to do. What do you want to learn more about, or what skills do you want to exercise? And we match those up with what our needs are. And we've been pretty successful with all of our universities in making that happy marriage. And we have the students working on meaningful projects, so things that we need help with, and you all have skill sets that we want. And so whether it's researching something for us or doing some data analysis or gathering information, being a detective, a variety of things, you have skill sets that we like to tap into, and so it works out really well. And we've been working at expanding our partnerships with the universities and with faculty members to get their assistance with things, and also to offer ourselves up as sort of a living laboratory. As Jennifer said, we're more involved in practice-based public health research than scientific laboratory research. But all of this helps inform the work of public health. So that's why we are very interested in that. And if you are interested in an experience with the Northern Kentucky Health Department, we are literally a short drive away. And you can go to our website, www.nkyhealth.org, and just type in Public Health Institute, and it will take you to the process that we use to get students on board.
Well, we're even a shorter drive away. So I'm not going to, I would agree with everything that's been said, and you're more than welcome to come and see us at any time. We have, I would encourage you to network through some of the associations that some of us may belong to, that perhaps like the American Public Health Association, if you're not already a member of that, the National Association of City and County Health Officials, it's NACHO, not NACHO, it's NACHO. It's a very strong organization that does a lot of, there's a lot of networking going on there. There's a state association of health commissioners and so forth, and they have, an opportunity. We actually, of course, we've been involved with the University of Cincinnati MPH project since, as Noble said, before its beginning. And are a firm believer in this, and are so pleased that it's it's getting some really good legs to it. Once upon a time there was no public health schools in the state of Ohio, and then the university up in Columbus and the one in Dayton kind of came into being, and it went from there. I believe there was also one in Cleveland, but we always needed one here, and now we have one. But I just wanted to say that all the schools now, that I think there's 9 or 10 public health schools, you would not believe how many they're reaching out to us. I just got an email yesterday from a student from Kent State, wants to come down and shadow us because she lives here. She's going to Kent State. Get to know the health commissioners. Get to know the folks. Come over and visit us. I mean, we're just a short drive away.
Well, let's thank our panelists for coming out today.